Good afternoon and welcome to United TV. We are about to do our Bariatric Friday. Today is March 28, 2025. Dr. Irgau is going to join me today. We have Dr. Gail Wynn. Last week we discussed weight loss drugs and bariatric surgery, the utilization of weight loss drugs. Prior to that, we have one of our patients who joined us. So it's been a couple of weeks that we haven't seen Dr. Irgau, although I see him almost every day. So he's back. So we are going to discuss another topic for the bariatric surgery process. And today is the day of the surgery that we are going to elaborate and explain what it means and what to expect directly from our bariatric surgeon. Dr. Irgau, how are you doing?
I'm doing great, and it's great to be back on Bariatric Friday. Definitely the highlight of my schedule during the week.
Well, thank you. Thank you for being with us. And I know you were watching the other episode earlier. So
which was great. It was very good.
It's good to have you. Bariatric surgery process is different than any other elective cases. So at a minimum, we spend about 2 to 3 months to get the patient ready. And now we are at that day. So you know how we have some of our patients when they have to do certain diets, certain changes. And today is the day that all those things are already done, and we are going to do the surgery. So in terms of the preparation, what are the most important things that we need to have directly to the surgery?
Absolutely. So the day of the surgery, obviously, there are some very important things that are going to happen right before the surgery itself. And of course, after the surgery, there are important things that the patient needs to be aware of. But in preparation for the surgery, of course, as you know, we do have a protocol for preparing the patients medically, obviously, and also we want them to be well educated and well versed in what is going to happen, particularly after the surgery, and how they will be adapting to the post-surgery life. Immediately, the 2 weeks before surgery, all patients are going to be on a special diet, which is a diet that is designed to shrink their liver. And we talk about this very often. And you actually called it the liver shrinking diet, which I do like that label, actually, because really the purpose is to decrease what we call visceral fat, the fat inside the abdomen, particularly on the solid organ like the liver, which tends to be very large when we are overweight. And it does anatomically cover almost the whole of the stomach sometimes. And really, when we do the surgery, we have to push the liver away in order to expose the stomach and undertake the surgery.
So this enlargement has nothing to do with alcohol, right? This is all with the weight.
Absolutely. That's actually very good point you're bringing here, because enlargement of the liver to that degree is one of the consequences of obesity. And not to go into another topic, but obesity itself may be becoming the biggest reason for liver failure in our country. It used to be alcohol in there.
Right.
So needless to say, the liver is large. We have to be able to move it away when we're doing the surgery. But if the liver is very hard, dense, and we try to push it, sometimes it can get injured. It can get fractured even. So making the liver a lot less dense, making the liver much more floppy is very important. And by doing that diet before surgery, we are able to achieve that. So even patients with very large liver, we're able to operate very safely by pushing the liver away from the area of the surgery.
So just want to put it in perspective for those. If someone was having elective gallbladder surgery,
Yes.
and if their BMI was 47, but they're not having bariatric surgery, it's just for the gallbladder, that would be as complicated as if it was a bariatric surgery. That's why it's important.
It is. To some extent, the position of the gallbladder is a little bit less cumbersome than the stomach, so you don't need as much shrinking of the liver. But many surgeries are actually moving towards this approach for many surgeries of the upper abdomen, because decreasing the size of the liver is very important for many surgeries in the upper abdomen. So this culture or this this habit that was started by the bariatric surgeons is being adopted by many other surgeons who are doing intra-abdominal surgery as well.
So my point on this is for our patients who are watching this. This is not a diet that you have to do for the bariatric process. It's just a diet to help the liver to get smaller.
Absolutely, absolutely, yes. We're not doing this because we want patients to lose weight before surgery. In fact, as you know, we used to really have issues with certain insurances that demanded that patients qualify for the surgery by losing weight first. That doesn't make any sense. Of course, we want patients to adopt a healthy lifestyle, and starting losing weight even before surgery is a good thing. We encourage that, but we don't demand that as a requirement before surgery.
Right.
So the diet we place them, as you correctly said, is specifically geared to making the liver smaller so that the surgery will be less challenging for the surgeon.
And by the way, that diet that we are asking patients to do, you and I, time to time we do it.
You do, yeah, absolutely.
I mentioned this a couple times. I'm doing it this week, and last week I did it. Sometimes I mix it, so I'm not doing it. I'm just replacing certain meals, and one is so practical, so it's easy. You just need to find your favorite type of the food. That there are different ones,
Absolutely.
the soup and the pudding and the drinks, but it actually also helps for the actual weight loss.
Absolutely.
For those who may be looking for losing like 5, 6, 7 pounds, because all of these patients, they come back with a lot of weight loss.
Absolutely, absolutely, they do, and that weight loss happens primarily from the internal organs. So it really makes the life of the surgeon a lot easier when that happens.
So, because the other thing that I want to mention, you were just saying earlier, we don't want to jump into a different topic, but I cannot help when we are talking about this. We want the best outcome in terms of the complications, the risk and complications when we have that topic. It's one of them to have the best preparation, and this is a really good preparation for the physical part of the surgery. That's going to make your life easier as a surgeon, and that's going to make it easier in terms of the outcome for the patient. Now, in terms of anesthesia, I guess one of the things that patients are asking, what type of anesthesia they are going through, what the safety, sometimes they ask, but we know that it's not a problem for us, but those who may not know what it is, can we kind of elaborate the anesthesia part of it?
Absolutely. The main bariatric surgeries that we perform, whether it's the gastric sleeve or the gastric bypass, are undertaken under general anesthesia. And with general anesthesia, what it means is that the patient will be completely asleep to the extent that even their breathing will be taken over by a machine that is operated by the anesthesiologist. So they will have a breathing tube that is inserted into their windpipe, and the anesthesiologist will be hooking that to an anesthesia machine that will be providing the oxygen that the patient needs through the surgery. And of course, the anesthesiologist will be having complete monitoring of all the vital signs of the patient second by second during the anesthesia. Now, general anesthesia nowadays is really the safest it's ever been. It's one of the areas of medicine that has been built with so many redundancies into it, so that there are ways for us to take care of any potential problems, just pretty much like they do in the airline industry, right? With so many redundancies built in so that safety is maintained to the very highest levels. It's the same with general anesthesia as well. Of course, every patient is not the same. We all come with different potential medical histories, and those are addressed and looked at by the anesthesia team before the surgery. There are very important considerations, particularly when it comes to bariatric surgery, because by definition, our patients are morbidly obese, and certain aspects of morbid obesity are critical for anesthesia. For instance, we always talk about airway. You know, when our patients come to the office, very often the first thing we will do when we examine these, we ask them to open their mouths and stick their tongue out. And what we're doing at that time, one of the things we're assessing is how accessible their airways are. Can we see the back of their mouths comfortably? Because that's what the anesthesiologist will be looking at as well. So being prepared to address any issues with any type of airway is critical for the anesthesiologist. And, you know, as you were saying earlier on, complications obviously can happen with any type of medical treatment or surgical approach. By far, the best way to take care of a complication, Kemal, is to prevent it. That is the key, right? So if your mindset is in prevention, you will have addressed many potential problems before they occur. And that's how you can maintain a very high level of safety. So yes, patients will have apprehension about anesthesia, particularly if they've never had any experience with surgery before. But anesthesia is really to very, very highest levels of safety nowadays.
Excuse me for that. Surgical techniques. Does that change per procedure and per surgeon? Are there different, does it vary depending on the procedure? Again, like your training versus someone who's junior to you, does that change at all?
So the actual procedure, you know, whether it's the gastric sleeve or sleeve gastrectomy or the gastric bypass, there are really some key aspects of that procedure that don't change regardless of who the surgeon is, right? One important aspect of surgery for weight loss that people need to know is that currently, by far, the vast majority of surgeries are being undertaken laparoscopy, okay? And this had made a huge impact on many aspects of bariatric surgery since we've adopted it. Our practice was actually one of the early adopters of laparoscopic approach to bariatric surgery. In fact, I am very proud to say that myself and my associate, Dr. Gail Wynn, were the first really to perform laparoscopic gastric bypass in our state. And also our practice was the first to perform the laparoscopic gastric sleeve. Dr. Peters in our practice, he was the first one really to perform in our state as well. So laparoscopy really is the mainstay. And what that means, Kemal, is that when we are doing surgery by changing different parts of the digestive tract to access that portion of the anatomy, we don't make a big incision like our teachers used to do and enter the abdomen with our big hands and manipulate things with our hands. We don't do that. We make small incisions, we call them keyhole incisions, right? And then we insert slender instruments as well as a very tiny little camera through those openings. We insufflate the abdomen by placing CO2 inside the abdomen. And then we have actually a camera that projects the anatomy onto a TV screen that is in front of the surgeon. So the surgeon will be looking at that TV screen and then will be utilizing their hands to manipulate those instruments and undertake the surgery. It's a really revolutionary way of doing surgery that has changed many aspects of abdominal surgery, including bariatric surgery. So the vast majority of the surgeries that we do, I can safely say more than 99.9% of the surgeries that we do is done actually laparoscopic, particularly the ones we do in the American Surgery Center, which is our day surgery place, the ambulatory surgery center, essentially. So, and with laparoscopy, essentially come many advantages for the patient. They don't have to deal with a big wound that has to heal, right? Which means that discomfort after surgery is much, much less than with open surgery where they would have a bigger incision. And then, of course, the scar itself, right? They don't have to walk around with a huge scar across their abdomen. They will have very small incisions that will very often not be very visible after the healing process has been completed.
Well, those kind of just making the outcome least complicated. So preparation, we talk about techniques, and that all gets better in time.
Yes.
And our program, actually, we adopted many of these early on. As you mentioned, like we are the first in many of these in bariatric. But also, you do a lot of general surgery, and what makes the surgeon a better surgeon is the number of cases, certain number of cases, and doing that successfully. But if someone is doing only 25 surgeries a year versus someone is doing 125, 125 is going to be a better one, even if the rate of the success is slightly lower. So, and this is why we are actually explaining some of these to make sure that, like, imagine, like, if this was, if we were having this discussion in 2014, and someone said, hey, the patient's going to go home same day. So this is one of the, I'm indirectly telling a patient that they're going to go home on the day of bariatric surgery. So they're going to stay 6 to 8 hour max, but right now we are averaging about 6. Same day going home. This would be, everyone would be looking at us like if we were crazy, right? But that's not what's happening. So our patients are going home. So one of the things that we are also expecting from them is to bring someone with them. They don't actually have to stay in the surgery center, but they have to be there at the drop of the patient and picking up the patient.
Yep.
Now, in our lobby, it's not too crowded, so they can actually spend the time there.
Yep.
But if they have some other work to do, they can. Well, I won't get into that just for today. We'll do it on a different week. So the idea of them going back home same day is huge. So
Absolutely.
now, from the surgeon standpoint, if you can actually tell us right after this procedure, post-op, the management of the pain and the discomfort, what they should be expecting from that point?
Absolutely. So management of pain after surgery, management of something like nausea after surgery is a very, very big part of the planning of the surgery itself. In fact, patients will be asked to take some medication even before the surgery. Very often they will be asked to take them as they leave their home to really prime their body to have less pain at the time of surgery, right? And we will be giving them very powerful medications before the surgery to minimize the risk of nausea, which very often happens after surgery on the digestive tract or just because of the anesthesia as well, right? So doing all those preparations really sets the patient for having a much quicker recovery even immediately after the surgery. Another thing that we do, which is very important actually, is that whilst the patient is asleep during the surgery, we administer local anesthetic, which is numbing medicine, strategically in certain parts of the abdomen where there are nerves that go to the places where we make the incision. So as patients are actually waking up from anesthesia, they feel very little discomfort. One of the things I talk about very often is that, in the past, in the early years of my practice, one of the things that bothered me most was to see patients waking up from anesthesia with a big frown, suggesting that they were in pain. And the anesthesiologist would respond to that appropriately by giving them pain medication.
Sure.
But to give pain medication after the pain has already started, actually, it does something to the patient that lingers longer, makes the whole recovery actually much more traumatic in a way. But having the patients preemptively devoid of pain as they are waking up sets them for a much better recovery. And they actually can deal with the discomfort that comes later that night or 2 days later much more manageable. So having patients prepared in this way and waking up with very little discomfort is really a very important part of what we do to get the recovery speeded up.
So what you said is really important. So again, for those who are listening to this, especially if they're going to go through the surgery, the first 2 hours is extremely crucial right after the surgery, and first hour is even more important in that 2 hours. So psychologically, when we are already in pain, that whole communication, even if we take something for the pain, after that pain hit us, we already believe that pain is there. It's almost like, how you and I, we talk about the stars, and then you tell me that they're actually not there. So, but then we still see them
That's right.
which
That's right.
we still need to discuss.
Yeah,
That.
yeah,
So
astronomy
we
discussions.
should have a different session for that one of
course,
these
of course.
days.
Would love to.
So the way that pain communicated in our body psychologically is the key. So if we know that this is going to happen, and if we put the precautions there, so then patient won't actually spend that time psychologically, again, the energy into that, how to handle that pain. So we need to prevent that to happen. So then we move on to the, okay, what may be coming after this. So that's really important, and not everyone really understands that. And I know that we are utilizing certain medications to make this better. And it's all about the patient experience. And, many people have dentist fear. I don't, because my dentist, I never had any pain when I was there, and I had a lot of dental work done. A couple hours later, I may need to take some painkillers on the day off, but like I'm talking about dental work. So, but during this procedure, never had any pain. So, and then going back there is not fearful anymore. So, and the same thing here. So then we want to make sure that expectation is there. So then there will be very little of all those troubles. And many hospitals, they don't do what we are doing. Because that medication is an expensive one, and we want to make sure that the patients are getting the best treatment from American Surgery Center. Now, in terms of the person who's assisting the patient, that their family member or friend, what should they prep for?
I think it's very important that, the support to be there, right? We don't really expect our patients to be physically dependent after they leave our center. We want our patients to be able to walk around by themselves. We want our patients to go around and get a cup of water or a cup of soup or whatever liquid that they're having by themselves. We expect our patients to be able to go to the bathroom and take care of things by themselves, right? But it is important to have a loved one to support them through this process. And knowing that you have a loved one with you, I think is very important. Now, for the day of surgery, as a requirement, we do want patients to be driven by somebody to our center, and we want them to be driven away from our center by somebody as well. Patients are not allowed to drive themselves away from our surgery center. That's important. And, obviously, bariatric surgery is a major, major event for our patients, and rightly so. So involvement of the family at that time is critical. Of course, many family members will stay in our surgery center, as you said. They will stay in our lobby. Some of them might accompany the patient until the patient is ready to go back to the operating room. And then, because there is going to be time for the surgery, which is the actual surgery doesn't take more than an hour or so, but there is recovery time. And during the recovery, the patient may not be accessible for family members, particularly the first 2 hours, as you were saying earlier on, in which case the family member may decide to go and do some chores or even go to work and then come back later. During this time, we will be in communication with them. Typically, the surgeon will be calling a family member. If they're not in the lobby, they will be calling them to let them know that the surgery went well. And then the nurses will keep them informed about the progress of recovery in the recovery area as well, to let them know what the expected discharge time is going to be, for instance. So that communication is going to be there with the family members all through the process.
Sure. And overnight, as long as they're following the discharge instructions in terms of what to eat, when to eat, how to eat, we don't have any special requirements. Movement is important. They need to be able to get up and move.
Absolutely.
Right?
Absolutely.
But that's important for almost every surgery.
Absolutely.
So,
Absolutely.
like when I took care of my mom in December after the heart surgery, every hour they ask us to take her.
Get her out of the bed, yeah.
And it was a very complicated one. And then knowing how important that is for that, for us, it's also very important for the patient to be able to get up and walk and follow the discharge instructions. And there are some patients, in terms of medication before surgery, the day of surgery, just the night before, they really need to pay attention to the nurse call that they have, because
Absolutely.
there are certain medications that we definitely want them to be off.
Yep.
And because of our case management process, we do identify certain medications early on.
Yep.
So they may be stopping certain things a week before. But those are going to come specifically from the nurses. And they also expect a phone call. They should expect a phone call from us next day.
Yep.
And then we do follow up with them 30 days after again.
Yep.
But one thing is crucial is, when do we want them to reach out to us? We know that they're going to have an appointment usually within 10 days for the post-op. But in what situations they should be calling us and not wait for the next appointment?
So, first of all, as a rule of thumb, we want patients to call us whenever they feel there is a need to call us, right? If they say, I need to call my doctor because of this reason, they need to call us. We're open 24 hours a day from access point of view, right? But in general, what I want to emphasize with patients is, of course, if they have specific symptoms like, throwing up, if they have fever, if they have pain that doesn't go away with the pain medication we give them, and of course, if they feel dizzy or anything like that, we need to be called.
Mm-hmm.
And there may be situations even that we may want them to call 911, of course.
Mm-hmm.
So they need to reach out. This is very important. But another general rule that I like to utilize to instruct patients is that they need to see progress in their recovery.
Sure.
Progress in every aspect, whether it's moving around, whether it's tolerating their liquids, whether it is taking pain medication, they need to see progress. So today should be better than yesterday. Tomorrow should be better than today. If they feel they are going backwards, in other words, today they're feeling worse than they did yesterday, call us. It should not be the case.
Right.
There should be progress every time they are longer and longer from the time of their surgery. They should be feeling better and better, stronger and stronger. So if they don't feel that there is that progression, we need to be called and we need to discuss this with them. And very often it may not be something to be worried about, but at least we can reassure them. So they should have a very low threshold to call us, particularly in the first 24 hours after surgery, 48 hours after surgery. This is very important. Of course, prior to being discharged, patients need to fulfill some important criteria. They need to be able to walk by themselves. They need to be able to tolerate the liquids that we give them, right? They should not have any other instability in their vital signs. All these criteria have to be fulfilled before patients are discharged. But even after we discharge them, when they go home, we want them to reach out to us if they feel there is any issue that needs to be addressed.
So the other thing that we want our patients to actually, even before the surgery, do is join our support groups. We have a couple different ways to do the support groups. One is it's a private group on Facebook. If you feel like you are too young for Facebook, then we have once a month support group chaired by Dr. Gail Wynn every Tuesday, every first Tuesday of the month.
Yep.
And then I really do believe a lot of patients are now watching what we are presenting in these sessions, and I feel comfortable because I have a surgeon with me. So then this is coming from the clinicians, and they can follow generic, broader issues direct from what we shared today. But anything specific should be coming from our nurses and our physicians in their visits. One other thing that I want to mention is what's going to make it really important for patients to do their follow-ups. This first 2 weeks, usually no one misses that one. I mean, I see a lot of maybe 1 or 2%. And the first month, the 3 months, and then other regular follow-ups that we have. But the immediate one is the 2 weeks. Usually we schedule it in the first 10 days. Make sure you make that appointment. Again, as Dr. Irgau, you said, if they have any issues in terms of anything that's abnormal and not getting better, reach out to us. Don't
Absolutely.
wait.
Absolutely.
We have someone on call. Even if it's a weekend, we should
Yep.
be able to call them.
Yep.
And that's what we have for today. Dr. Irgau, these are, I know patients are benefiting from these and other people are watching. One of the other things that as we are doing the interviews on the surgical PA position, a lot of them, they already watched a couple of the episodes in preparation for their interviews. And they told me a couple of them, and maybe you have the same experience, that they actually want to watch the other episodes because there were a lot of clinical learning. And hopefully this is reaching out to our patients. We'll be back next week with another topic. And thank you for being with us and have a great weekend.
Thank you.
Bye-bye.
Bye-bye.